Hello, good afternoon. Good afternoon, everyone. This is Dr. Velma Scantberry, and I am the Medical Director for Dialysis Patient Citizens Educational Center, and I am here for your first Wednesday of the month Ask the Doctor session. So thank you guys for joining today, and I hope the weather in your location is as nice as ours. It's not as sunny, but we've had a weekend of rain, so I appreciate all of you jumping on to put your questions in the chat. So again, I'm Dr. Scantberry, and we are here to discuss anything you want to talk about this month of October. This is the 2nd of October, and so we are generally, October is Breast Cancer Awareness Month. So certainly we want to make sure that it is certainly an important topic, as we know that for women it could easily be detected. We want to make sure that those of you who are, whether you're on dialysis or whether you've had a kidney transplant, how important is cancer screening. And not just breast cancer. We're talking about that because this is October and I'm wearing pink for breast cancer. But basically being aware of your risks of cancer. And so making sure that you're doing all the screens. And you know that for those of you who are being worked up for a kidney transplant, on the list for a kidney transplant, or have gotten a kidney transplant, the importance of cancer screening. Because that is something that we generally want to make sure that you are not at risk for cancer or have any cancer. Certainly it doesn't mean that you will not get transplanted, but it means that you will need to go through treatment, make sure that your cancer has been eliminated or is dormant, or is cancer-free before they can proceed with a transplant. Because the goal of transplant is to wipe out your immune system so that your body can take care of itself, but not reject the kidney. So unfortunately, when you have a cancer, you then open up the window for, you're going to need treatment, and so it sometimes can conflict with some of the medications. You want your body to be strong, so that is often they're trying to boost your immune system. So certainly it can be a conflict. So certainly it is important. And so many of you may not necessarily, I actually had a patient recently who was not added to the list because they felt that he was a high risk and his chances of death with the transplant were worse than remaining on dialysis. And so for many patients, getting that bad news or not qualifying for a transplant can be really earth-shattering. But for patients, it's really, I try to have them understand that it's the risk-benefit ratio. Not everyone will qualify for a transplant, and that's kind of hard to hear because you want that hope. You want them to be able to say, how can I make my life better? But then there's also others who can optimize their function on dialysis such that they can still lead an optimal life. So it all depends on the reasons why they were not suitable candidates for transplant. If they have underlying heart disease, then one of the good things is that going through the process of being worked up will get you a cardiologist, will get your heart optimized, will connect you in a way that you can help improve or stabilize your heart function. So while you may necessarily not be a good candidate for the transplant, certainly you've gotten connections to learn more about how to optimize your health. Certainly it may be simple as, we can help you live a life that may be event-free by optimizing your dialysis, not gaining weight, seeing interdilated weight gain should be at a minimum, and seeing your cardiologist to make sure that your heart's doing well, even though you're on dialysis. So how do you comfort them? Seeing that even though you're not a candidate, you can still optimize your life on dialysis. And I know there are many patients who have survived on dialysis for 20, 25 years or even longer. So there is ways to understand that, but also understand that dialysis itself is not going to fix a lot of your other metabolic problems. So sometimes those problems, regardless of whether you're in dialysis or not, may be issues from that standpoint. So those are the things you have to look at and decide, how do I make these better? Are you diabetes free when you receive a pancreas transplant? The goal in getting a pancreas transplant is now you have obtained an organ that puts out insulin. And just like any other transplants, certainly you want to have the optimal pancreas transplant that makes enough insulin to come off come off of your insulin injections. So just as kidneys sometimes will take slow to wake up, and you may make urine, but your kidney function is not great. Certainly with pancreas, you can have a slow start where you now not need as much insulin until gradually you are able to not require outside insulin when the pancreas is at its full function. So certainly when the pancreas is at its full function, you should not require insulin from the outside. Some patients may go into rejection, and you'll notice that by the hemoglobin A1C or the C-peptide may be higher, and so they are looking to say, okay, something's going on with the pancreas. Oftentimes that may be a late sign, but generally you want to biopsy early on and make sure that if there's any rejection, that you're treating it early before it affects your need for outside insulin. So that's very important. Some people wonder, well, why do I need a biopsy? Certainly some people get a pancreas and a kidney from the same donor. It's a little it's trickier to biopsy the pancreas because there's lots of big blood vessels in there. So oftentimes they'll biopsy the simultaneous kidney, knowing that if rejection is there, it's likely some going on with the pancreas as well. But it's also possible to have rejection in one and not rejection in the other, but it's not very common. So thank you for that question. So yes, you do reverse your diabetes, but the effects of, you will see some patients, the goal of having a pancreas early is before it affects your diabetes, lead to damaging heart disease. Some people's vision may already be affected. They can see a slight improvement, but generally you may slow down the progression of the effects of diabetes, but generally the reversal is not going to be dramatic, or it may not happen at all. If a doctor recommends embolization of a kidney, what are the risks? Depends on the reason for embolization. Oftentimes it can happen for various circumstances. For instance, if your kidneys are not functioning and you're already on dialysis, but there's something that's occurring that's driving up your blood pressure, then if the kidneys are already small and shrunken, there's really not a lot of danger. The risks are that once you have embolized the main arteries or the blood flow to the kidney, you're now left with tissue that will die off over time, and so there's always a risk of infection within that dead tissue, and will it get absorbed in its own area and without causing pain or discomfort. Sometimes we may choose to shut down a kidney or with embolization for high blood pressure, but it's generally only for that certain part of the kidney. Oftentimes, but you may experience for any embolization, depending on how big the artery or how small, and the subsequent tissue that will be affected by cutting off that blood supply is generally going to determine what you're going to experience after, such as pain, discomfort, because now you're going to have tissue that no longer has blood supply and may slough, and you generally want to do it at a time where you know that there's no risk of infection. For instance, if you're having pyelonephritis and you have an infection in your kidney, not a good time to embolize, because you don't know whether that infection will infect the tissue that is no longer getting the blood supply, and then you end up with a general infected kidney. So thank you for that question, and it's oftentimes not something that's done routinely, and is basically depends on the reason. sometimes we have patients who have extremely high proteinuria. They're on stage 5, but we want to be able to shut down the native kidneys because they're wasting so much protein. But we don't generally will embolize in that situation. We would choose, or they may be considered, the importance of maybe using some medications that may drive the renal function, make it worse, so that you stop putting out extremely high amounts of protein in your urine. So thank you so much. Welcome to our board president, Andrew Conklin, is here with us. Thank you. Thank you so much, Andrew, for attending today, as well as all our other regulars. So another question, is it advisable to have your fistula removed after a kidney transplant? Most people would say no, not really, unless it becomes an issue. In the immediate 5 years, I don't think anyone will remove it, because sometimes the fistula can be used for infusions that a big vessel is needed, instead of using you having a catheter in your neck. So if you can often use the fistula with permission with your nephrologist. But oftentimes because the fistula itself is made out of your vein as opposed to a graft, which is a foreign tissue, removing the fistula itself is usually adherent to its surrounding tissues. The substance of the fistula itself can be dilated and stretched due to the flow, and therefore very difficult to remove. If you have an aneurysm or a thrombosis, and now you have a specific area that needs attention, then the vascular surgeon may go in and remove that section. But to actually get it out of the tissue, you have to consider the risk-benefit ratio. And most of the time, many patients after transplant, the fistula may clot off by itself, and then it becomes useless without having to take it out. But if there's an aneurysm or clot, they can remove that section. Generally, if a fistula gets high flow and is jeopardizing your heart, because now you have a high flow fistula, you have a functioning kidney, and it's making your heart worse because you have a waterfall of blood going through your fistula and dumped in your heart. For some surgeons, they would band that fistula so that you reduce the flow by a certain amount, but keep it. And others, they may just tie it off entirely and let it involute over time. So grafts are easier to remove because they're foreign substance, and it's easier to detach them from your surrounding tissue. But the vein itself, as your fistula made from a vein, it is adherent. You will cause a lot of destruction trying to get the pieces out. So oftentimes just tying it off or removing that section is all that's done. So thank you so much. And Yolanda, want to highlight there's so many patient ambassadors: Jennifer, Alethea, Brisbane, great to have all of them representing here, California, Michigan, and New York. So thank you all for being here. This is wonderful, and I appreciate you all, especially those on the West Coast, for logging on. It must be pretty early for you. So thank you for your questions. And many patients are not aware of treatment options. Is that fact or myth? Unfortunately, in 2024, we should say that all patients should be aware of the treatment options. But it is also true that many patients who, especially if they are diagnosed in an acute situation, may not necessarily have those options discussed at the time of their diagnosis, because there's so much going on. For many patients who have a slow or is seeing their primary doctor refer to their nephrologist, then they may be given that information before they hit dialysis or whatever modality they choose to have. But the majority of people in the acute situation may, if they're diagnosed in the emergency room, in the hospital, didn't know that they had kidney failure because of the urgency of hemodialysis, that may be all that is presented to them early on. But we know that coming up later this month, there's a session on Instagram on options. So it's really important to know your options and understand what are the advantages and disadvantages of whether it's peritoneal dialysis, hemodialysis in-center, hemodialysis at home, and also knowing that the importance of understanding that you don't have to be on dialysis in order to be referred for a kidney transplant. And so some of that information gets missed. If you are early diagnosed, you can be given that information ahead of time so that you can talk to your family, see if there are any friends, not just family, to think about early preemptive donations so that you can even avoid dialysis as you get to stage 5 and plan that transplant so that it is done at a time when you need replacement therapy. Remember, even if you're not on dialysis and you can get preemptive therapy, that transplant is put off until you really need an option. So I can have someone understand that they've had their relative come forward or their friend and they worked up, and we said, okay, you may be able to wait and in agreement with the nephrologist until you're ready for treatment, and that would either be dialysis or a kidney transplant. Many patients are listed on the transplant list not being on dialysis. As long as you hit that EGFR of 20%, you can get on the list for transplant. But you may not be ready either mentally or may not be at that time to say, well, I don't have, what are my advantages and disadvantages? I am not on dialysis, I'm listed for transplant, I'm feeling well, I'm working full time, I have no complaints, I am not overly fatigued, my memory is still in good tact, and I'm not experiencing any significant side effects of my end-stage renal disease. So is it time for me to go ahead and get a transplant, or do I wait till I'm feeling poorly? So those are things you discuss with your nephrologist in terms of deciding when it is appropriate to accept a kidney if you're on the waiting list and not experiencing any issues. But if you are, and your doctor is saying, okay, you look like you're going to be headed to dialysis within the next month or two, well, you better think about accepting any possible kidneys that may be that you agree with your transplant surgeon is good for you at that point in time. Another question is, often patients get depressed and want to stop dialysis. How do you encourage them to stay on dialysis? Well, dialysis is your lifeline. If you stop dialysis, then certainly you're thinking about dying. So it's really about getting you treatment for that depressed mode. And it's okay. Depression is an illness. It's not something you cause. It's not something that you can fix on your own. And so recognize that there is often a need for intervention. There's still a significant stigma around mental health. Last month was Mental Health Month. We had a great conversation on one of our local channels about suicide and depression. And so many people face that feeling worthless and that there's no benefit to life. And so recognize that requires treatment so that you can have a positive outlook on life. If you are feeling like that, it's because you're down, and medication can help. Therapy can help. Talk to your your staff at the dialysis unit. Get some help, because therapy and medications can lift you out of that gutter and make you feel better, so that you have a better outlook on life. Try to do things that are with other people. Encourage your family to help you. But most of all, talk to someone. Seek help, because it's not abnormal to be depressed on dialysis. You have to be able to understand that there's something better out there. There's ways to improve my life overall. There are ways to add activity to my life to make it beneficial. So there are ways to work with those around you to see the positive side of life in order to feel better. So thank you so much for that question. And generally these days with mental health, there's so many people who are seeking help. Our office here is a primary care, but we have mental and behavioral health therapists, because when someone is in need, it's good to have someone that they can talk to, or they don't have to go in the phone book and find someone to accept their insurance. So it's very important that you encourage those you know who you think may be suffering from depression, who may need some help. Just ask them, are you thinking about, do you have suicidal thoughts? It's okay. Talk to those around you so that you can really advocate for others and help them get help. So thank you so much. Many patients on dialysis suffer from a urine smell. How can that be remedied? That's one I might stump me. So when you talk about urine smell, the question is whether or not you are. Most people don't have much urine. There are those who still on dialysis and they have a small amount of urine, and then there are those who may not be urinated at all. So I am not familiar with that urine smell if you're not making urine. So if someone have any answers, you can put them in the chat for me. So I appreciate that question, but I don't have an answer to it. Thank you, Nancy. You stumped me on that one. Anyway, any other questions? Hi, Greg, Yolanda. You guys are having a good chat, and make sure I haven't missed any questions. And thanks for all being here. Again, I'm Dr. Scanterbury. I'm the Medical Director at Dialysis Patient Citizens Educational Center, and today is October 2nd, and I'm here to answer your questions. We've been talking a lot about dialysis issues as well as transplant, feeling better. Being that this is Cancer Month, I'm reiterating for those of you, if you're male, make sure you get your prostate checked, make sure you get your colonoscopy. And if you are female, make sure you get your colonoscopy, but also make sure you get your mammogram and your cervical pap smear, because those are things that are needed for getting on the transplant list, but it's also to keep you from dying of cancer. You may do well on dialysis, but you may not necessarily want to die from cancer when there's treatment out there available for those things. So if it's not you, encourage your family, encourage those around you, friends, co-workers, to remember to go get checked. I know here in Delaware, we are probably the leading state for triple-negative breast cancer deaths in Black women. So we are encouraging. One of the things we do is making sure that our patients get cancer screened. If they have abnormalities, follow up with that biopsy. It is not a death sentence in most parts, but for even if you're on the transplant list, you can still get treated for your cancer. And once your oncologist says that you are cancer-free and you've gone through your treatment, and they are with a follow-up PET scan or however they are following you, verify that you no longer have any evidence of tumors around, then you can be put back on the list for transplant. Generally, transplant after malignancy, they're a little bit more careful about what kind of immunosuppression you get in terms of not overdoing it with the early immunosuppressant drugs, just to make sure that there's no reactivation of your cancer. But there are many, many patients who have gotten transplanted after being treated for cancers, and there are patients who develop cancers even after transplant and continue to have those treated without much danger to their transplanted kidney. So thank you so much for that. Any other questions? Let's see. Someone wrote that self-care is paramount when dealing with chronic diseases. Absolutely. It's a different picture for everyone. For me, it helped to read, participate with others, dialysis patients while I was under treatment. So very, very important to get involved. There were some recent articles that talked about loneliness and how, it can lead to depression and mental issues as well as physical issues. So it is important to stay connected and in terms of those who are around you, whether it's your bingo group or you're join a book club, something to keep you entertained and to also keep you connecting to others where you can have conversations and also keep your brain active. Is there such a thing as being number one or number two on the transplant list? Certainly for many centers, you may come up being the first or second, but if you're an adult, you can also be bounced down the line by a pediatric patient. You may be number one on this O list for your center, but when you look at the other centers who are sharing the same list, they may have 6 patients ahead of you. But while you're one for your center, you're still not up for kidney because other centers may have patients that are take priority over you based on the time on the waiting list or antibody levels. Sometimes you may be number 1 or 2 on the list, but the donor, you think you're getting that kidney, but now there's a donor, and that patient who's getting the liver also needs a kidney, so there goes 1 kidney, and you don't get any because you're kidney alone, and double organ trumps single organ. And that person may be on the list as a prior donor will supersede you as number 1. So every time there's a new potential donor, the DNA of that donor is then put into the algorithm, and so you may have equal time with 3 or 4 people who are shuffling the number 1 and 2 and 3 positions based on the DNA of the donor. So until those patients ahead of you get eliminated or transplanted, then your turn will come up in comparison with the other persons on other transplant lists. So remember, you can be number 1, but suddenly this transplant center down the street have listed a patient who have 15 years on dialysis, and suddenly they're ahead of you because they have more dialysis time and you've lost a spot. So it really changes every day based on people being added to the list or people being removed because of a transplant. Where could a person see a map of which states are included in each region? Some may not know that they can list in multiple regions in multiple states. So even you can go to unos.org or help anyone in your transplant center. UNOS usually be able to transplant.org. You can pick your state and then pick the number of transplant centers in that state and the number of organ donation centers as well. And so you want to be able, sometimes a state may have more than one organ donation center, may have more than one region. So for instance, a state as big as Texas may have multiple regions, but it's all about, can you get to that region if they call you, if you're listed in that region, and are you able to stay around that hospital? So generally people will say, okay, if I live in New York, the waiting time is 12 to 15 years. I have a relative in Pennsylvania. I'm going to list in PA, and if I get called for a transplant, I can stay at my cousin's house, or I can look to see if they have a family house that may be affordable for the 2-3 weeks or even month that you may have to stay in the area. So yes, you can list in multiple places, but make sure that when they call you, you're able to jump up and get there within a couple of hours or maybe even by the next day. So thank you so much for that. Is it safe to return to a catheter if a new fistula is not working? If the fistula isn't working, certainly they will try to make sure that they can fix it in one way or another. But oftentimes, if the catheter is still in place and is not infected and is still capable of being used, certainly you can return to that until they fix the fistula. The fistula might need revised or changed in order for it maybe even mature somewhat in order to function properly. So it may be a temporary fix. It's okay to do that as long as you're not thinking that this is how you want to dialyze long term, because it's never good to dialyze via fistula long term unless that is the only way that's possible. And after a while, that will become an issue and it'll have to be moved to another site. So thank you so much. We've reached 1 o'clock, and I appreciate all the questions and all those of you who were attending. Excuse me. Thank you for being here, and I'll see you next time. Thanks so much. Take care.